Prashant is a prolific vitreoretina surgeon. He is also a prolific quiz master. Yes, Prashant, let's see here.
Okay, thank you. Yeah, can you see my slides now?
Yeah.
Well, I'm supposed to speak on giant retinal tear. It's not proceeding.
You
click on the slide.
The arrow on the bottom.
Click on the slide
on
and
the
then
bottom.
Yeah.
Okay, correct.
Good. Yeah, thank you. So everyone knows that giant retinal tear means a tear which is more than 3 clock hours, and typically it has the edges have a tendency to roll back. Once upon a time, a dreaded detachment. Now it is quite a comfortable surgery because of improved success rate, because of that improvement in technology and better understanding of the pathophysiology of this disease. Wide angle weaving system, perfluorocarbons, small gauge vitrectomies, high speed cutters, and now vault cannulas have added comfort to the kitty of vitreoretinal surgeons. So these are my 10 pearls for people who do vitreoretina. First, most important thing, however tough the any surgery is, to keep your basics right. And so here is the basic what we teach our postgraduates or fellows. You have to confirm the placement of infusion cannula once you place it inside the vitreous cavity. Well, here you can see the flap of the giant retinal tear was blocking the infusion cannula. And that would have meant a subretinal infusion of the fluid which was going inside the eye. So you need to trim it with the help of a vitreous cutter adequately, so that the infusion cannula, the flow through of the fluid through the infusion cannula happens unhampered. The second thing is the controversy about putting an encircling band or a buckle in a case of a giant retinal tear. Well, all vitreoretinal disease, especially detachments, have an abnormal vitreous base, which leads to tangential traction. So if you put an encircling band or a belt buckle or a scleral buckle, that leads to relief of this traction, which is likely to reopen the break or lead to extension of into uninvolved retina. Fine, the point against it is that giant retinal tear, which is usually more than 180 clock hours, acts as a retinectomy, which leads to release of traction otherwise also. Yes, so buckle has a limited role, especially in a phakic patient with inferior giant retinal tear or a patient who is having PVR along with this. And this giant retinal tear should be less than 180. If it is more than 180 degrees, please, there is no need of doing a belt buckle. And if you have to put a belt buckle, it should be seeing that it should be low height and the giant retinal tear should lie flat on the surface of the buckle and not on the edge of it. Well, the second most important step, or the most important step during vitreoretinal surgery, is the induction of PVD. Fortunately, in the case of giant retinal tear, PVD usually pre-exists, except in cases which are secondary to trauma or familial vitreoretinal degeneration, when the vitreous is very sticky. The other challenge of induction PVD is that when you are doing an active suction here, because of a closed space, it comes into a cutter. So you can create a space by draining subretinal fluid. Then the other way is to help two instruments to maneuver, remove the membranes over the posterior pole, and then create a space by putting a PFCL bubble. And after putting and stabilizing the retina over posterior pole, then you continue peeling the membranes and the PVD induction into the periphery. Now, another important step during vitreoretinal surgery is about the base excision. Here, the setting of a vacuum, setting of a vitreous cutter is at a low vacuum and a higher speed, preferably 10,000 cuts or something like that. So let us see some of the examples. So this here, I'm doing a vitreous base excision. You have to do adequate base excision that will prevent reproliferation. More importantly, you should concentrate on the horns of the edges of the giant retinal tear, which should be free of the vitreous in the opposite meridian, because residual vitreous in the opposite meridian leads to reproliferation. And you can see under air, I'm doing the base excision of the opposite meridian adequately. Now regarding the lens, Should a crystalline lens be sacrificed for having an adequate vitrectomy and base excision is always a matter of debate. But yes, we firmly believe that there is no need to sacrifice a crystalline clear lens. Well, the only indication for removing a lens is when it is cataractous or there is a pre-existing subluxation or dislocation. This is a video that demonstrates the base excision, a clear phakic eye under high magnification, and you can see the beautifully. If you depress hard the sclera and get the pars plana into the mid-vitreous cavity, you do not need to, you will not hurt the lens, and you can do an adequate base excision. What is the need? Well, you can see 180 degrees. You are doing absolutely. You can even see the ora serrata here. Okay. The anterior flap of the giant retinal tear, whatever is the residual flap, is tissue, and it acts as a scaffold for anterior loop and rubeosis. And therefore, the dictum is it should always be excised. As you can see, I'm excising the anterior residual flap of the giant retinal tear with the help of a vitreous cutter. And it should be done adequately. Sometimes you have to depress the sclera to reach out to the last bit of the residual flap. Well, there are certain situations where you cannot remove the residual flap for some reasons. And if you have a residual flap, do not leave it like that. You can laser it so that the rubeosis does not happen. It does not lead to ischemic response and rubeosis. Now, once you have cleared the vitreous, you have done the base excision, naturally you have to unfold the retina, and that is very challenging. So this is a case of a 270-degree giant retinal tear where I am now using two instruments. One is light pipe and the other is a flute needle, just to unroll the flap, identify the disc. And once you identify the disc, you slowly have to inject the PFCL bubble, keeping a watch on the pulsation so that you do not inject and create a IOP high, as well as see that you raise the bubble height up to the edge of posterior edge of the giant retinal tear. After that, you roll it in the opposite direction and you will have a, you can remove the residual fluid behind it. Now, after removing, after putting a PFCL bubble, you also need to unfold the flap, retinal flap, which can be there. Like you have put a PFCL bubble, the JRT flap has not well unrolled itself completely. Well, you can use a blunt forceps or a brush needle or something like that, a blunt instrument, to just unroll the flap which has got rolled under, or at the roll which has not opened under the PFCL bubble. And see, slowly nudging the rolled in flap, you can just flatten the retina under PFCL. Giant retinal folded flap here, and pulling the retinal flap, trying to unroll and remove the fibrous tissue there. But equally important in such cases is the removal of the peripheral associated PVR. Unless you remove the PVR in the periphery, in the other quadrants as well, this flap is not going to flatten. And therefore is the importance of removing the flap, even at the cost of retinectomy. The tissue is quite fibrous there. And you can see persistent, if you are persistent, you can even roll such a stiff flap. Once you unroll the flap, you need to laser it under PFCL initially, and the laser burn should be moderately gray. It should not be white. Basically, that means you have caused necrosis, and that will lead to further proliferations. And so here under PFCL, I'm putting 3 to 4 rows of giant lasers just behind the edge of a giant retinal tear. After that, you do a fluid air exchange, partial fluid air exchange, PFCL exchange, and under air, you are completing. You have to give more importance to the edge of the horns of the giant retinal tear. Here you can put additional few rows of laser, because these are the areas where the giant retinal tear can give way. I have spoken about the importance of lasering the residual flap, anterior flap, to prevent rubeosis. Now, after PFCL is put, naturally it has to be replaced at the end with the air or with a silicone oil. There are two ways. You can either do PFCL silicone oil exchange, which is a messy affair, at least at my hands, I prefer to do PFCL fluid air exchange, and then air, once you have air in the vitreous cavity, I put the silicone oil, which is an easy thing. So how do you prevent the posterior slippage while you're doing this step is, you should avoid high broad buccals, and the PFCL should be brought up to the edge of giant retinal tear. Now I will show you, these are various 180-degree giant retinal tear, 320-degree GRT, and this is 360 giant retinal tear with PVR, and how I prevent slippage. This is with a fluid needle under passive effusion. I'm tapping the every millimeter of the giant retinal tear. You have to be very meticulous, very patient. And if you tap and milk out the last drop of the subretinal fluid at the edges of giant retinal tear, the unrolling of the flap is not seen. Well, that was 180 degrees. This is 270-degree giant retinal tear. Only this area is attached. And see, I'm meticulously in every millimeter wise. I go all 270 degrees to tap every millimeter of giant retinal tear. And so at the end of the procedure, you will see there is not a millimeter of slippage of the flap. And this is 360-degree giant retinal tear, where I have intentionally created because of severe PVR. We have done a 360-degree giant, retinectomy. And you can see, even in such aggressive 360-degree GRT, in spite of PVR, which has been relieved, if you do meticulous tapping all around 360 degrees, there is no slippage. Well, not all giant retinal tears are just plain giant retinal tears with detachment. Sometimes they have associated pathologies as well. So here I see an epiretinal membrane and a PFCL, and I'm trying to peel the ERM. So you have to tackle the concomitant pathology which exists along with it. Then I stain it and then remove the internal limiting membrane. Well, this is another concomitant pathology. You have a macular hole with a severe PVR as well. So here, macular hole, already Ajay has very well said. What is the basic principle is to peel internal limiting membrane and relieve the traction. But in these cases with associated peripheral PVR, relief of peripheral PVR is equally important, so that macular hole also closes as well as the retinal tear flattens. And this is what exactly I'm doing. After peeling the ILM, I'm also trying to remove the peripheral PVR. The retina was very stiff in these cases, so we had to do a 360-degree giant retinectomy. And once we did a retinectomy, retina could fall flat and the macular hole could close simultaneously. Sometimes it is associated with more severe PVRs like this. And here, tackling the concomitant pathology in the form of severe PVR with GRT is another challenge, which I would just run through it. And this is another case of severe PVR along with giant retinal tear. So tamponade, yes, silicone oil is a preferred tamponade, as you must have seen, especially so in inferior GRTs PVR. Gas is restricted to only few cases of superior GRT, which are fresh enough and where the separation of retina is not significant enough. But by choice, it is silicone oil. Well, you follow all the pearls on a given day, but sometimes it's not a day, your day. So you will see in this case, well, I have done everything fine. Now I'm doing PFCL air exchange. And at the end of the procedure, what I notice is a small pocket of fluid subretinally. Well, it is such a small, and the retina otherwise is not slipped. So you can leave and the next day it will be flattened. Well, here, when I'm doing fluid PFCL air exchange, you can see PFCL bubble going beneath and the retina started unfolding. Well, you just have to be patient, use a flute needle to tap those PFCL bubble, and then again start tapping the edges of giant retinal tear, and under air, it will flatten. So persistence. So be persistent, be meticulous, follow the rules, you will win the war. And this is the last case where we have done 360-degree giant retinal tear. And when I finish the thing, I notice a residual fold over here. In such severe PVRs, you have to accept such folds, and most of the times in due course, once you position after silicone oil, this fold will flatten. So friends, if you follow all these rules of managing a giant retinal tear meticulously, most of the times you can put smile in not only on the face of your patient, but also on you for doing a good